Hey guys, welcome to MedMaster, where today we talk about Guillain-Barré Syndrome or GBS. GBS is an autoimmune disease and there are antibodies produced against peripheral nervous system. Peripheral nervous system consists of every nerve in your body except for the brain and the spinal cord. So even the cranial nerves are part of the peripheral nervous system and are involved in GBS. These antibodies lead to demyelination and axonal damage. Myelin is the cover that surrounds neurons and has a key role in speeding up the nerve conduction. So the demyelination leads to reduced nerve conduction velocity or speed. GBS usually occurs 2 weeks after an infection or vaccination and usually takes 4 weeks to resolve. This is all you need to learn Guillain-Barré syndrome. GBS is a symmetric sensory motor autonomic polyneuropathy. GBS is a polyneuropathy. Poly means multiple and neuropathy means that peripheral nerves are involved, so the brain and spinal cord is intact. It is symmetric, so the left and right limbs are involved similarly. It has sensory involvement, so the patient suffers from back pain and paresthesia or tingling of fingers and toes, and sometimes numbness. The most prominent involvement in GBS is motor or movement involvement that results in weakness. Here we call it ascending weakness because legs are firstly involved and then we have the involvement of the trunk and upper limbs. The combination of this sensory motor involvement leads to absent or decreased DTR or deep tendon reflexes. In GBS, we also see autonomic nervous system involvement. Autonomic nervous system is composed of sympathetic and parasympathetic nervous system, and as you know, they are responsible for maintaining blood pressure and heart rate. So, when they are involved, the patient may experience fluctuations in their blood pressure, extreme hypotension or extreme hypertension, and also variations and fluctuations in their heart rate. So they may experience bradycardia or tachycardia. Here we have the characteristics of motor involvement in GBS. As I told you, it is an ascending weakness, so it usually begins in lower limbs and progresses to the trunk, upper limbs, bulbar nerves, and respiratory muscles, and consequently respiratory failure. In lower limbs, the weakness is usually more prominent in distal parts, so the patients may be unable to walk normally. We also have bulbar nerve involvement in GBS. Bulbar nerves are cranial nerves 9, 10, 11, and 12 that originate from medulla oblongata or bulb. They are responsible for swallowing. So when we have involvement of these nerves, the patient may experience dysphagia or difficulty swallowing and aspiration of food into their lungs. They are also responsible for controlling speech, so the patient may experience hoarseness of the voice or nasal or hypotone speech. They can also present with chewing problems. There are other nerves that can be involved, like facial nerve that leads to facial palsy or facial muscle paralysis, and also extraocular muscles that are responsible for the movement of the eyes. This can lead to diplopia. But the one and worst muscle involvement that we fear is respiratory muscles that lead to respiratory failure. This is the first cause of mortality in GBS patients. Now, for the sensory involvement in GBS patients, as I told you, the patient may have numbness and paresthesia. Paresthesia means tingling and is mostly seen in distal parts of the hands and feet. This is called stocks and gloves polyneuropathy. These patients also have back pain, and as an important tip, you need to know that there's no sensory level in GBS. It means that borders between different sensory dermatomes are involved. Actually, sensory levels and urinary incontinence or prominent urinary retention is in favor of other diagnoses like spinal cord injuries and transverse myelitis. Guillain-Barré syndrome has three subtypes and they are classified based on different patterns of weakness and different autoantibodies produced. Here I'm going to talk about the three most important one of them. Firstly, we have acute inflammatory demyelinating polyneuropathy or AIDP. As the name suggests, the prominent feature of this subtype is demyelination that occurs in neurons. The second one is called acute motor axonal neuropathy or AMAN. Here we have axonal damage and is more severe than the previous one. And the third subtype is Miller-Fisher syndrome. Here we have a triad of ophthalmoplegia that is due to extraocular muscle involvement, we have ataxia, and also areflexia. As I told you before, GBS usually occurs 2 weeks after a respiratory or gastrointestinal infection. Germs that are best known to cause GBS are Campylobacter jejuni, Mycoplasma pneumoniae, and also Zika virus. Vaccines can also cause GBS. The most important one of them is the swine influenza vaccine, and also we have rabies vaccine and meningococcal vaccine. In GBS patients, we do lumbar puncture to obtain CSF or cerebrospinal fluid. When we analyze it, we see a high CSF protein or albumin, but white blood cells are not elevated, and this is called cytoalbuminologic dissociation. Here we have normal glucose levels and also negative CSF culture. And in blood, we may see mildly elevated serum CPK or creatine phosphokinase that is due to inactivity of the patient. Also, it is possible to measure antibody levels like anti-ganglioside antibody. Other studies that can help us diagnose GBS include MRI findings like contrast enhancement of nerve roots because nerve roots are part of the peripheral nervous system and in GBS they are involved. Here we also have NCV or nerve conduction study. This shows us peripheral nerve inflammation and also reduced motor and sensory conduction velocity or speed that occurs due to demyelination in GBS. EMG or electromyography can help us too. It shows acute denervation of muscle, and because of all these modalities available, nerve biopsy is almost always not required. So, what happens to patients with GBS? Most of them spontaneously recover after 2 to 3 weeks, but it can take even months to recover. Respiratory failure and autonomic involvement in these patients are dangerous and can lead to death. Weakness usually but not always resolves completely. When the recovery begins, the first organs involved are the last one to recover, and in these patients, fatigue may last for a long time, and some of them may experience relapses in future. And lastly, for the treatment and management of these patients, we need to admit them to a hospital, whether this is a neurology ward or ICU or intensive care unit, depending on the severity of symptoms. We need to regularly check their respiration, progression of their weakness, whether they have dysphagia or not, and monitor their blood pressure and heart rate. In severe cases, the treatment is consisted of IVIG or intravenous immunoglobulin and plasmapheresis or plasma exchange to get rid of the autoantibodies in the blood. As an important tip, you need to know that steroids are generally not effective in GBS treatment, and we also should give the patient a good supportive care. We can give them respiratory support and take some measures to prevent pressure sores and prevent deep vein thrombosis. Also, analgesics are important in the pain management of the patient. That's it, guys. I hope you enjoyed this lesson. If you like this kind of content, please like, subscribe, and comment.